Hello, good morning, everyone, and welcome to the Orlando GI Journal Club for October. This is October 2nd, 2024, 7 a.m. here in Orlando, Florida. Good morning, everyone. Our first study is by Greer et al. This was published in the American Journal of Gastroenterology, and this is looking at the performance of non-endoscopic screening for Barrett's esophagus and esophageal cancer in veterans. Barrett's esophagus is the only known precursor of esophageal cancer, with identification of Barrett's esophagus the only strategy for preventing esophageal cancer or early detection of esophageal cancer. The major limitation of current guidelines is that it recommends EGD in patients with GERD and Barrett's esophagus risk factors, or patients with refractory GERD or those with alarm symptoms, is that it fails to detect Barrett's in patients with well-controlled symptoms on PPI, and also fails to detect Barrett's patients without GERD. Now, less than 5% of esophageal adenocarcinoma are diagnosed as early-stage lesions caught by surveillance of patients with previously known detected Barrett's, and the incorporation of non-endoscopic detection methods in outpatient setting could increase the detection of Barrett's. EsoCheck is a non-endoscopic esophageal balloon sampling device, and that, coupled with EsoGuard, is currently FDA approved for minimally invasive alternative to EGD for detecting Barrett's esophagus. And the aim of this study was to determine the diagnostic performance of EsoCheck combined with EsoGuard testing in a screening population. This was a prospective study conducted in a single center, the Veterans Medical Center in Cleveland, USA. Veterans meeting the ACG guideline criteria for endoscopic Barrett's esophagus and esophageal cancer screening were included. They included men aged 40 to 85 years with symptomatic GERD, plus 3 additional risk factors for Barrett's, which is white race, obesity, being men, smoking history, family history of Barrett's or esophageal cancer. EsoCheck was performed first, unsedated, followed by screening EGD sedated on the same day. The result of the EsoCheck was not available at the time of EGD, and the biopsies were taken during EGD when short or long segment Barrett's was visualized on EGD following the Seattle protocol. The primary outcome measure was the diagnostic performance of EsoCheck compared with EGD for detection of Barrett's esophagus. So overall, 124 patients were included. They found 16 patients with Barrett's or esophageal cancer, and 108 patients had GERD. And as you can see, they did include a very small proportion of women, 4 patients overall. The majority were men, 97%. 86% of the patients included were white, mean age of 63 years, BMI of 31.4. At least 78% of patients had a history of smoking. There was 4.8% family history of smoking. 54% of the patients included said they were drinking alcohol, and the mean number of risk factors present in this population was 4.1. Now, looking at the diagnostic performance of EsoCheck, the prevalence of Barrett's esophagus diagnosed on EGD was 12.9%, so they found 16 patients. The table on the right shows the details of the 16 patients who had Barrett's. 2 patients had adenocarcinoma in the setting of Barrett's. And if you look at the Barrett's length per the Prague criteria, the longest Barrett's is C10M12, and the shortest is C0M1. Now, looking at the performance of EsoCheck compared to EGD, assuming that EGD has diagnostic accuracy of 100%, sensitivity was 92.9%, specificity and positive predictive value were lower, specificity of 72.2%, positive predictive value of 32.5%, and negative predictive value of 98.6%. The overall procedure acceptability on a visual scale going from 0 to 10, where 10 is most acceptable, was 7.23. Now, if I explain the diagnostic performance and what they mean, sensitivity means that out of everyone with the disease, so with Barrett's or adenocarcinoma, how many tested positive with EsoCheck? So that's 93%, so that's very good. Now, another factor that was very good on EsoCheck is a negative predictive value. That means negative predictive value basically means that out of everyone who tests negative with EsoCheck, 98.6% do not have the disease. So it looks like EsoCheck is very reliable if it tests negative. However, we run into a slight problem with the positive predictive value, which is very low at 32.5%. So positive predictive value means that out of everybody who tests positive for EsoCheck, only 32% has the disease. That means that there were a lot of false positives with EsoCheck. In some ways, with this kind of test, where you want testing to be as sensitive as possible, having a low positive predictive value actually is not a bad thing, because if EsoCheck is falsely positive, the patient will have an EGD anyway. So it, I guess, forms some kind of protection if you're trying to diagnose as many people as possible with Barrett's. Unfortunately, this does mean that patients are exposed to an EGD unnecessarily because they do not have Barrett's. However, EGD being a relatively safe procedure to perform, and the risk of Barrett's and potentially finding adenocarcinoma in these patients is such high yield that I think is probably not such a problem. Specificity of 72% is low. Specificity means that out of everybody who do not have the disease, so who do not have Barrett's, 72% tested negative. So this test, not perfect, but definitely helpful, is I think what this study showed. Now, the limitation of this study is that in the veteran population, being predominantly a male dominated patient population with a lot of risk factors for Barrett's, there is the elevated prevalence of Barrett's and esophageal cancer in this population, which fortunately can lead to referral selection and participation bias. Also, because this is seen as a screening tool, you have to compare it to a gold standard, and by default, you're assuming the gold standard is 100% perfect. And so in this study, you're assuming EGD is 100% perfect for for detecting Barrett's. But as everyone knows, EGD is not 100% perfect for detecting Barrett's. It is operator dependent, and so it is not reflective of clinical practice. So the main take-home point from this study is that EsoCheck coupled with EsoGuard has high sensitivity and high negative predictive value for diagnosis of Barrett's in a screening population of veterans. The next study is the randomized trial by Hanoa and Bruce Sands. This is looking at the subcutaneous infliximab as maintenance therapy for IBD. This is two randomized phase 3 trials called the Liberty trials. So these are the results of subcutaneous infliximab versus placebo in patients with both UC and Crohn's. And that's why there are two randomized trials. One randomized trial is for Crohn's, one randomized trial is for ulcerative colitis. CTP13 subcutaneous, or SC, is the subcutaneous formulation of the intravenous infliximab biosimilar CTP13 IV. So what these authors wanted to do was look at the efficacy of a CT-P13 sub-Q versus placebo as maintenance therapy in patients with Crohn's disease and ulcerative colitis. So the results in the study reflect 2 randomized trials in patients with moderately to severely active Crohn's in one randomized trial, and moderately to severely active ulcerative colitis in the second randomized trial, who have inadequate response or intolerance to corticosteroids or immunomodulators. This is phase 3 trial, placebo-controlled, double-blind. All patients received initially an open-label CT-P13 intravenous, which is the infliximab biosimilar, at 5 milligram per kilogram at weeks 0, 2, and 6. At week 10, they took the patients who responded to the initial induction therapy with the CT-P13 IV, and they were randomized in a 2-to-1 ratio to CT-P13 sub-Q, 120 milligram, or placebo every 2 weeks until week 54 using pre-filled syringes. The primary endpoint was looking at clinical remission and endoscopic response in Crohn's and clinical remission in ulcerative colitis at 54 weeks. So this is the result of this randomized trial. So looking at Crohn's disease first, they were able to enroll 231 patients in the subcutaneous treatment group and 112 patients in the placebo group. For the Crohn's randomized trial portion, the median age was 36 in the CT-P13 group, 29 in the placebo group, 58% were men in the CT group, 62% were men in the placebo group. If you look at the ethnicity, the majority of patients were white, 91% in both groups, thereabouts. If you look at the BMI, it was 22.7 in CT, 21.8 in the placebo. The timing since active Crohn's disease diagnosis was mean of 4.34 years in the CT group, 4.45 years in the placebo group. If you look at the mean CDAI score, it was 311 in the CT group, 309 in the placebo group. If you look at the CERP, mean CRP, 18.89 in the CT group, 21.29 in the placebo group. The fecal calprotectin levels, 2,585 in the CT group, 1,951 in the placebo group. Now, if you look at their prior treatment of immunomodulators at baseline, 27.3% in the CT and 32% in the placebo group had used azathioprine previously, and in 42.9% and 39.3% in the CT versus placebo groups, respectively. They were treated with oral corticosteroids at week 0, so at the start of the trial. When looking at the ulcerative colitis portion of the randomized trial, 294 patients were enrolled in the in the CT group, 144 in the placebo group. Again, the median age was 37 in the CT group, 39 in the placebo group, slightly more men than women in both groups, 55% in CT, 58% in placebo. Again, the majority of patients enrolled were white, 98% in CT, 97% in the placebo group. If you look at the BMI median of 23.3 in CT, 24.7 in the placebo group. If you look at the time since ulcerative colitis diagnosis, 6.09 years in CT, 6.80 years in the placebo group. Now, if you look at the baseline severity of the disease, the modified Mayo score was 6.6 in the CT group, 6.7 in the placebo group. The total Mayo score was 8.8 in the CT group, 8.8 in the placebo group, And CRP at baseline was mean of 8.6 in the in the CT group, 0.32 in the placebo group. Fecal calprotectin levels, 2,681 in CT group, 2,441 in the placebo group. 21.4% and 20.8% respectively of patients in CT and placebo had used were using azathioprine at baseline. And if you look at the use of corticosteroids at week 0, it's 40.8% in the CT and 42.4% in the placebo group. Now, if you look at the endpoint in the Crohn's disease at 54 weeks post therapy using either sub-Q CT or placebo CT, this is placebo here in gray. If you look at the CDAI score, it was significantly higher in the CT group at 62.3 versus 32.1, and p-value was 0.0001 with estimated treatment difference of 32.1%. If you look at the percentage of patients who had endoscopic response, the estimated treatment difference was 34.6%, with 51% in the Crohn's disease group and 17.9% in the placebo group having achieved endoscopic response, and this p-value is 0.0001. Now, if you look at ulcerative colitis, patients achieving clinical remission was 43.2%. In the CT group, 20.8%, 20.8% in the placebo group, with an estimated treatment difference of 21.1%, p-value of 0.0001. If you look at the adverse events, patients with at least one adverse event was 72.3% in the CT group, 61.9% in the placebo group. For UC, 7.6% in the CT, 59.3% in the placebo group. Now, if you look at serious adverse events, the rates were low and comparable between placebo and CT, 6.7 in CT, 7.6% in placebo for Crohn's, 6.4 versus 2.9% between CT and placebo in the ulcerative colitis patients. If you look at patients with adverse events leading to drug discontinuation, overall is 3.8% in CT, 4.8% in placebo. In the Crohn's disease, 3.4 versus 2.9% in CT versus placebo in the ulcerative colitis group. If you look at adverse event leading to death, that they saw one death in the CT group in the Crohn's disease study. No other deaths were noted. The main limitation of the study is that there is no direct comparison between CT P13 IV and CT P13 subcutaneous formulations. And the take-home point from this randomized trials that CT P13 sub-Q formulation was more effective than placebo as maintenance therapy and was well tolerated in patients with moderately to severely active Crohn's and ulcerative colitis who responded to CT P13 IV induction. Now, this is our recap for the Journal Club this week. EsoCheck coupled with EsoGuard has high sensitivity and high negative predictive value for diagnosis of Barrett's esophagus in a screening population of veterans in the United States. CT-P13 subcutaneous was more effective than placebo as maintenance therapy and was well tolerated in patients with moderately to severely active Crohn's and ulcerative colitis who responded to CT-P13 IV induction. All right, thank you for joining us for this week's Orlando GI Journal Club. Our next Journal Club is on November 6th, 2024, which is the first Wednesday in November. I thank you so much for joining us this morning. Please have a wonderful day, week, and month, and I look forward to seeing you in November. Please have a wonderful day. I really mean it. Thank you, everyone. Bye.